Welcome and thank you for joining. My name is Trixie Thibodeau, Health Educator for Community Health at Atlantic Health System. Today's webinar is Understanding Your Cervical Health and is being presented by Dr. Nana Chabo. But before we begin, I have a couple of announcements. The webinar is being recorded and will be shared in its entirety on our website. All participants are muted. If you have a question, please use the Q&A button at the bottom and use the chat feature for comments. We will get through all the questions at the end of the presentation. Are you a loved one or interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about the groups and other resources, or for additional dates and times, please call 1-844-472-8499. I will also put that in the chat so you have it for later reference. Okay. Now I'm going to stop share, and Dr. Chabo, you can share your slides now.
Thank you. Can you see it properly?
Yes.
Okay.
Yes, I do.
Thank you. Good afternoon. My name is Dr. Nana Chabo. I'm a gynecologic oncologist here on staff at Morristown and Overlook Medical Centers with Atlantic Health System. And I'm pleased to present today Understanding Your Cervical Health. I thank you for the invite for the Community Health and Care Coordination Department, as January is National Cervical Cancer Awareness Month. Our learning objectives today are that participants will be able to list how to prevent cervical cancer, why regular screening is important, and where they can get screened. Also to describe lifestyle changes and health screenings that can reduce the risk of or prevent reproductive tract cancers. So a little bit about anatomy. The cervix, which you see on the bottom right here, is a cancer. The cervical cancer is a cancer of the cervix, which is the lower portion of the uterus or the womb. The cervix is the part of the uterus that opens into the vaginal canal and dilates during labor. The normal cervix has two main types of cells: the squamous cells that protect the outside of the cervix, and the glandular cells, which are mostly inside of the cervix. That's what produces the fluid and mucus commonly seen during ovulation. You see the body of the uterus here, where you would carry a baby or where you would shed your cycle when you're having a menses. And then you see the ovaries to the sides of the uterus with the connecting fallopian tubes. What's not visualized here is the vulva or the labia or the lips, which are external genitalia. So just looking at cancer as a whole as of 2020, cancer drastically obviously changes the lives of many women in the United States. But with the empowerment of knowledge, more women are participating in prevention and screening activities, which are reducing the risk of dying of these diseases. Breast cancer is the more common cancer that affects women at over 276,000, with unfortunately 42,000 deaths. Uterine cancer, endometrial cancer at 65,000, ovarian cancer 21,000. Cervix is, as of 2020, was at 13,800 new cases a year, with 4,290 deaths. And vulvar cancer, a cancer of the external genitalia, was about 6,000 cases, with unfortunately over 1,000 deaths. Cervical cancer rates are still far higher than they should be, since unfortunately over half of the women with this diagnosis have not had a Pap test in the past 3 years. So let's talk a little bit about cervical cancer screening. The primary goal of cervical cancer screening is to detect treatable abnormalities and precancerous changes of the cervix, as roughly takes about 10 to 15 years for a serious precancerous change of the cervix to turn into cancer. So this long phase of precancerous changes can provide an ideal target for cervical cancer screening. The goal, again, is to detect any precancerous changes as well as early cancers, and that's done by pap smear screening, which takes a brush to take a sample of the cells off the cervix, applied either to a slide or a vial, which is evaluated in the laboratory for cervical cancer screening. Most times now you're going to see the pap smear is a liquid-based. In the past, we used to place the cells on slides and fix it with a fixative. That wasn't always very accurate. So the liquid-based cytology also allows us to test for HPV, which we'll talk about later, human papillomavirus. You can also test for other infectious diseases or sexually transmitted diseases on the pap smear as well. And then we'll talk a little bit about HPV vaccines and how that can be helped to prevent cervical cancer as well as other cancers related to human papillomavirus. So the pap smear itself was actually developed by George Papanicolaou in 1928. Kind of realized in 1941 that it was quite effective in detecting abnormalities to the cervix, and it's dramatically decreased cervical cancer mortality. Unfortunately, as any screening test, is not 100%, so there will be errors in sampling, errors in transferring cells from the cervix to the vial, errors in interpretation of the results themselves, and errors, unfortunately, evaluating those abnormal results. So currently there is some controversy with regards to pap smear screening. I've been in practice since 2000, and during that time, there's been guidelines changing seems like every year on how often we should be having pap smear screening. Initially, when I first started my training, it started when a woman was first sexually active. Then it changed to age 18, then it changed to age 21. Some societies recommend 25. So it's changed quite a bit over the past 20 years. But the American College of Obstetricians and Gynecologists, ACOG, as well as the US Preventive Task Force, recommends not starting pap smear screening until age 21. And if it's normal, every 3 years, women should have pap smears between the ages of 21 to 29. Human papillomavirus, again, which we'll talk about in a bit, can also be tested on the pap smear after age 30. The reason why it's not tested frequently before the age of 30 is the thought that the HPV infection can be transient, and therefore you're potentially doing a lot of additional procedures on younger women that can have obviously cause anxiety, can be uncomfortable, can be painful, and can also have an effect on future fertility. So the human papillomavirus testing is usually after the age of 30 is when you do that in addition to the pap smear. It's recommended to stop pap smear screening at 65, which I think is also a controversial recommendation, as women obviously can develop cervical cancer later in their lives. Now, the American Cancer Society, which is different than ACOG and the US Preventive Task Services, is not recommending screening until age 25. That's not commonly practiced by most gynecologists, and again, ending at age 65 for screening. If women have had normal pap smears before the age of 65, it's recommended to stop screening because the thought that they would have a new partner that may expose them to HPV later in life is less likely. If you've already had a hysterectomy with your cervix removed, it's also not recommended to continue pap smear screening if your pap smears were normal in the past. And as we talked about, the DNA testing for the human papillomavirus is not recommended in young women, as again, it can be a transient infection. So when we look at pap smears, there's a lot of different results that you'll see. Normal or negative is the most reassuring result. You'll see a diagnosis called ASCUS, A-S-C-U-S, and that means there can be some atypical cells seen on the pap smear results. You may see LSIL, which is low grade, and what we get most concerned about is HSIL, or high grade, on the pap smear, because that's typically an indication of having precancerous changes. So the pap smear is one part, but then you also sometimes have to follow up with a biopsy to see if there are any additional concerns. So when we look at this transition here, some people like pictures, some people don't, but this would be more mild changes to the cervix here on the left, where you see these whitish changes on the cervix. Typically the cervix is a pink, in color and doesn't have any whitish changes. When you start seeing more whitish changes in the middle, and when you start seeing more kind of reddish changes or abnormal blood supply to the cervix, that gets more concerning for higher grade changes or potential cervical cancer. So there's a transition that you can visibly see on the cervix with time if patients are exposed to human papillomavirus and develop precancerous changes to the cervix. And again, when you potentially, if you have an abnormal pap smear and potentially need a biopsy, these low-grade changes, the CIN1 or the mild changes you may see, tend to be able to regress on their own in as much as 60% of cases. So that's why these cases can be more observed. If you have the more moderate to severe changes, the CIN, which is cervical interepithelial neoplasia, precancerous changes of the cervix, those can progress in months to years. And that's why we usually recommend careful monitoring or potential procedures on the cervix to remove these changes. But again, typically it takes years for the precancerous changes to progress to cancer. That's why it's so important for women to be getting their pap smear screening so that we can detect any changes early, as opposed to unfortunately finding them later when the treatment options are more invasive. So if you have an abnormal pap smear, your physician or provider may recommend what's called a colposcopy. So that is similar to a pap smear test. It does require a speculum. A vinegar-like solution is placed onto the cervix, and a microscope is used to look at the cervix. And if you see those whitish changes we saw previously on the other pictures, those are the areas you would want to biopsy to see if there are any precancerous changes that need any further management. So again, the mild changes, mildly abnormal, is the CIN1, and usually can be watched closely as the majority of lesions regress on their own. The CIN2, you can sometimes be more conservative in younger women who may be interested in future childbearing, because all the procedures on the cervix can have an effect on future fertility. So you can sometimes watch those changes closely with serial pap smears on more frequent monthly, like 6-month intervals, or potentially have an excisional procedure to remove a portion of abnormal cells of the cervix. The highest changes, the CIN3, are considered the most concerning, for cancer or precancer. And those are typically the areas you'd want to excise, usually in the operating room, in order to remove precancerous cells before they potentially become cancer. And if a woman is diagnosed with cervical cancer, it's very important she's followed by a gynecologic oncologist. We, again, have special training in obstetrics and gynecology, as well as gynecologic oncology. And it's been shown that patients that are treated by gynecologic oncologists have a more superior outcome. So there are a variety of options for treatment. Sometimes they can be done in the office. Sometimes they are done in the operating room. You'll hear maybe terms like a LEEP, L-E-E-P, or a laser procedure. Those procedures are excisional procedures, meaning that a portion of the cervix is actually removed to remove the precancerous cells and hopefully normalize the pap smears for the future. Cryotherapy is a frozen technique or a freezing technique that's used to freeze the cells as opposed to remove them. The cone biopsy also is a procedure usually performed in the operating room under anesthesia to remove a portion of the cervix. And sometimes it can be diagnostic, meaning that it diagnoses whether or not a patient has any precancerous or cancerous changes, and that can be therapeutic because it can also treat them. And occasionally the removal of the entire uterus and cervix may be needed due to the pap smear or biopsy results. So this here again is the anatomy that we saw briefly earlier. You have the cervix here on the bottom, the vaginal canal here. This is the womb or the uterus. Again, the ovaries to the side, the fallopian tubes to the side. And when you have the cone biopsy, you're removing about 8 millimeters to a centimeter of the bottom part of the cervix to remove the precancerous cells. So it removes the cells from the outside of the cervix, as well as deeper inside of the cervix. This is a procedure, again, done for the highest concerns, the CIN3, as the concern is you want to make sure you're not missing any early cancer. Obviously, any of these procedures, again, can have an effect on women's fertility. So you have to be careful when you're counseling the patients of the risk of scarring that could develop in the cervix, or also placing them at risk for potential preterm labor or preterm delivery in the future, as when the cervix is shorter, sometimes it's difficult to carry a pregnancy to term. One program that we have here available at Atlantic Health, if patients meet financial eligibility, is the Morris County, New Jersey Education and Early Detection Program here at Morristown Medical Center that helps to provide both free cervical and breast cancer screening, again, to appropriate patients. And this number is where you would call 973-971-5952. So looking again at cervical cancer, while hopefully patients have had their cervical pap smear screening, unfortunately, cervical cancer obviously still exists. Worldwide, it's the fourth most common cancer in women after breast cancer, lung cancer, and colon cancer. In 2020, you had about 500,000 cases worldwide, with over, unfortunately, 300,000 deaths. And most of these cases, as well as these deaths, are occurring in developing countries where access to pap smear screening and HPV vaccines is definitely less available. Again, in the United States, we're looking at about 13,000 to 14,000 cases a year, with unfortunately 4,000 deaths yearly. And we look globally across the continents. Obviously, you can see the varied cases where you have the 14,000 cases in the United States and Canada, and in areas such as Africa, 67,000 cases, varied areas in Asia with over 150,000 cases. Again, unfortunately, where access to the pap smear screening is not readily available. And unfortunately, in the United States, you're going to see a high proportion of disparities with regards to cervical cancer. Again, unfortunately, where there's less access to care, less resources, less providers, that unfortunately often affects women of color, as well as women in Appalachia, with less, again, access to care. So women that are Hispanic women living along the US-Mexican border have higher rates. African-American women, particularly those who live in the Mississippi Delta region, the white non-Hispanic women that live in Appalachia or rural New York, American Indian women, Vietnamese American women, and areas with limited resources. Again, as you can see on this map, unfortunately concentrated in most of the southern region of our country. So again, there are quite a concern for disparities with regards to cancer care, particularly with cervical cancer. Again, this tackles race and ethnicity lines, age, as again, women over 65 are having less access to screening, as the guidelines are recommending not screening them at this time. Women that are immigrating to the country may have less access to healthcare. The health literacy of the populations may affect their ability of importance or knowledge of how important it is to have your pap smear screening and your socioeconomic position. So access is a big issue. Again, geography, as we saw on that map of the US, the providers that are available to treat the community, as well as deficiencies of health in our healthcare system with obvious racism. So when we look at cervical cancer, sometimes it can be a failure to screen, where women in higher poverty areas or those with lower education or older age aren't screened as a whole. That's the majority of reasons why, unfortunately, we have higher cervical cancer rates in these populations. If the cancer is not detected properly, either because of how the specimen was collected or how the slide was prepared, or difficulty interpreting the results, or again, if there's rapid progression of their case, in between the pap smear screening, or unfortunately, what can happen is if you don't have the appropriate follow-up. So if patients have an abnormal result and aren't able to get back to the physician to be treated, these patients, unfortunately, could have progression to cervical cancer. So there's about, I think, 168 million women in the United States, and about 50 to 60 million women in the United States have a pap test each year, of which only 3 to 5 million women actually have an abnormal result. So the majority of patients will have normal results on their pap smear. and can follow those guidelines to have screening not, less regular, like every 3 years or every 5 years with the HPV test, as we'll discuss. But if your pap smears are abnormal, you don't follow those guidelines, you have to have more rigorous follow-up to make sure we can detect any precancerous changes that could progress to cervical cancer. The lifetime risk of developing cervical cancer for United States women is on average about 0.6%. I've seen teenagers develop cervical cancer, although it's extremely rare. Most women are in their 30s to 50s, although there is a larger population, maybe about 15%, that can develop it after the age of 70. Most importantly, what's a big take-home point from today's presentation is most cervical cancers can be prevented if women have appropriate access to care. So you'll see here from 1930, again, I said that pap smear first came out, I guess, in the late 20s. And you'll see the screen that with every decade, we are seeing a decrease in the incidence of cervical cancer. But the reason why it's not zero is, as you can see, for the past decades of 2000 and 2005 there, we're not unfortunately reaching the unscreened population. And so that's the reason why cervical cancer rates have not decreased as much as they should. Okay, and a concern obviously about women of color, particularly African-American women, is incidence mortality is approximately 50% higher. They did some studies in Georgia, and they found that, again, women may not have access to the screening. Unfortunately, there's a lot of provider mistrust, given how African-American women have been treated and our African-American population have been treated in the past by the healthcare system. And so there's a lot of disparity in their outcome, despite the incidence of cervical cancer being similar in the African-American and Caucasian population in Georgia. The unfortunate mortality is much higher in African-American women. So this here is a picture of an abnormal appearing cervix. We saw those pinkish changes to the cervix previously in the little whitish changes, but this is an actual tumor on the cervix, on the top part of the cervix here, where it should be just a pale pink and a small opening here where the cervix would dilate to have a child, but it's been replaced, unfortunately, by a tumor. So with regards to cervical cancer, obviously, with all cancers, patients do better if their cancer is diagnosed early. So if it's confined to the cervix, there are more conservative treatments that can be undertaken, and surgery is still an option for patients. If there's more spread to different areas of the pelvis, then patients are better treated with radiation and chemotherapy. And if it's quite advanced, then sometimes patients receive supportive care or palliative care for their support. Generally, the 5-year survival of cervical cancer is quite high for stage 1, can be as high as 96%. As any cancer progresses, this 5-year survival is less. So again, the importance of the pap smear screening is that we try to prevent patients from getting to cervical cancer, where more invasive treatments are needed, and obviously survival can be affected. So again, surgery is an option, radiation is an option, chemotherapy is an option. We're coming up with newer agents every day with clinical trials, looking at targeted therapies as ways to treat cervical cancer that identifies patients' different tumor characteristics and tries to find a way to target the cancer in that form. Immunotherapy is a different way to treat cancers nowadays as well, where you use either not vaccines per se, but drugs that are used to rev up a patient's immune system to try to tackle the cancer that way. This again is a picture here of the uterus and the cervix. If a patient needed a more invasive approach to treat her cancer, that's why these surgeries are quite significant, because they take tissue not only around the cervix and the uterus itself, but they also take tissues of the vagina, and they also sample lymph nodes as well. So these surgeries are quite extensive, but can be quite successful for patients with earlier stage concerns. We used to do a lot of the surgery laparoscopically through smaller incisions. More recent research has suggested that patients will do better with an open approach or traditional incision on the abdomen as opposed to the smaller incisions, that the survival is actually better with an open approach to the cancer. So you're going to see less cases offered with smaller incisions because of this new data that has been shown. For young women who may not yet have started their families and are still interested in doing so, it's important to give them every opportunity to try to have a family despite the cancer diagnosis. So there is a procedure that's called a trachelectomy, which means you remove the cervix and then you connect the uterus to the vagina. So again, looking here, this is the uterus here. The bottom part of the womb is the cervix, and the longer part here is the vagina. And you need to remove the cervix if it's a smaller cancer, and the tissue around the cervix and the upper vagina. And then you connect the uterus to the vagina with a suture inside that helps the uterus and the cervix stay in place, so that a woman could potentially still have children delivered by C-section. So that is a pretty radical procedure that was actually designed in France and now brought to the United States and other countries to offer younger women the chance to still have children despite the cervical cancer diagnosis. So again, surgery is an option, and for earlier stage patients, patients with more local disease do get often radiation and chemotherapy, and we're always looking for clinical trials to find better ways to treat and potentially cure cervical cancer. So you can't really discuss cervical cancer without talking about human papillomavirus, or HPV. So HPV causes cervical cancer in 99% of cases. It's the most common sexually transmitted infection. And in our lifetime, probably 80% of us will have been exposed to HPV. The thought is that when we're first sexually active, we can be exposed and usually clear it within a couple years of exposure. Those patients that don't clear it from their system are those that are at the highest risk of developing not only cervical cancer, but a multiple other host of cancers that are related to HPV. So there are over 200 types actually of human papillomavirus, of which 40 can target the anogenital region. You'll have the 2 low risk types that can cause genital warts, and there are about 13 different types that can cause high risk cancers and precancerous changes to the cervix. You may see on your pap smear that they'll actually identify 16 and 18, because those contribute to about 70% of cervical cancers. And then you'll see high risk HPV other types. So that's all the other numbers we see here that can contribute to precancerous changes of the cervix and the cancer, but aren't the HPV 16 or 18. So again, HPV 16 is the most common high-risk type worldwide, accounts for up to 70% of cervical cancers. And HPV 18 accounts for the other 20% of cervical cancers. That's more common in the cells that are deeper inside our cervix, the cervical adenocarcinomas. And depending upon where you are in the world, the varied HPV strains will differ. So again, at least 80% of women will have been exposed to HPV by age 50. The incidence is roughly about 6 million cases per year. And the prevalence, meaning how many people at a time have HPV, is about 20 million. Most often develops from, obviously sexual relations, and usually when patients are first sexually active. So not only does HPV 16 and 18 cause cervical cancer, it can also have an effect on vaginal cancer and vulvar cancer, cancer of the external genitalia or lips. The other cases can also contribute to the genital warts, as well as the more mild cases of cervical change, the precancerous mild changes of the cervix, the vulva, and the vagina. Not only is HPV associated with cervical cancer, but it's associated with head and neck cancer from oral relations, HPV 16 being the most common type. There's not, unfortunately, a way to screen for HPV in the mouth, except if you are seeing a dentist or an oral surgeon and they identify a concern in the mouth on exam. Anal cancer is related to HPV, vaginal cancer, vulvar cancer, penile cancer. So a lot of these anogenital regions can be affected by human papillomavirus. So when we look at HPV infection, one of the things that women need to stop doing is smoking, because smoking can definitely play a role in making it difficult to clear HPV from your system as your body is immunosuppressed from the tobacco use. And they've actually done studies where they have found in the cervical mucus, they've actually found the nicotine and they found the cancer-causing agents from tobacco use in the mucus of the cervix. So one thing I definitely tell young women is if you don't smoke, please don't start. But obviously it's a wonderful way to improve your overall health by stopping smoking, but definitely to improve your cervical health as well. Obviously, following a healthy diet is good for all cancer risk prevention. Patients with HIV and other immunocompromised conditions are at a higher risk for human papillomavirus because, again, it's difficult for them to clear the HPV from their system. And when we look at how much HPV costs our US healthcare system, it's estimated to be in the role of about $5 billion. When you combine pap smear screening, you combine pap smears that had false results that required more biopsies, when you look at the precancerous changes of the cervix, when you look at the treatments needed for genital warts, for patients with cervical cancer, for patients with non-cervical related HPV cancer, that's quite a cost to the healthcare system. So everything that we can do to now, I'm going to transition to talk about vaccines, would be ideal to try to reduce this burden on the individual patient, their families, and the healthcare system. These are resources, research and programs to reduce disparities in cervical cancer. You have the National Breast and Cervical Cancer Early Detection Program. There's a patient navigator program with the National Cancer Institute. The CDC has a racial and ethnic approach to community health, as does the Intercultural Cancer Council. And it's also on good resources, the Cancer Prevention and Control Research Network. There are also educational materials available in different languages, such as Spanish, as well as different Asian languages as well. So with regards to vaccines, so what is the HPV vaccine? It's actually developed, I think, in 2006, but the vaccine that's now readily available is called Gardasil 9, and it actually is looking to prevent 9 different types of HPV for both boys and girls. Obviously, there are 200 types, so that's why it's not 100% effective, but it does tackle 16 and 18, 6 and 11, and the other varied types there that cause about 90% of cervical cancers. So HPV vaccine produces the strongest immune response in pre-teenagers. Usually between the ages of 9 to 12, it's first recommended, hopefully before these young individuals are sexually active. That's when it's most effective, before you become sexually active. And usually the ages at between 11 to 12, that's when it's thought to be the most ideal time to receive the series of shots for both boys and girls. You get about 2 doses of the HPV vaccine if you start between 9 and 12. And it's, even though it's approved now to age 45, the vaccine was initially approved for ages 9 to 26 years of age. So for those that have not been vaccinated and are still under the age of 45, that's still an option for the patient. But usually the effectiveness is less if someone's already been sexually active, as likely they've been exposed to HPV as it's so prevalent. So there now have been more than 270 million doses of the HPV vaccine that have been distributed. Obviously, every vaccine is monitored very carefully for safety. The most common side effects include headache, fever, nausea, and dizziness. It's not uncommon also to have some pain and redness at the site of injection. If you have a severe allergy to yeast, it's not recommended to receive the vaccine, as there is a component of yeast in the making of the vaccine. There also have been some studies that have shown the risk of fainting after the vaccine. That's why it's typically recommended that people of all ages are watched for about 15 minutes after the vaccine to reduce the chance of this fainting complication. And then a last slide here about condoms helping with HPV. So the reason why condoms aren't 100% effective with HPV is because it's not in the vaginal secretions and in the semen that HPV is spread. It's actually spread by skin-to-skin contact. So there's just not a condom large enough to cover the entire genital area. And it also doesn't protect same-sex female partners from contracting the virus. Even though, again, you may have no symptoms from HPV, and even if you have precancerous changes, you may have no symptoms either. A condom isn't 100%, should be still used, but is not 100% to eliminate the risk of HPV. So the vaccine, all we have right now are preventive vaccines. There are vaccines looking to be therapeutic, to be treatment vaccines. Those are still in research and are not commonly available at this time. But again, if you can reduce by cancers by about 90%, I definitely recommend that parents consider these vaccines for their teens. So they asked me also to talk about some other cancers. So I know we have a few more minutes. Again, with regards to breast cancer, unfortunately, 1 in 8 women will be diagnosed. It's one of the most common cancers we face as women. I can't implore enough how important it is to have a mammogram annually. Can definitely save your life. It's usually recommended to start at the age of 40. Unless you have a family history of concern that would prompt earlier screening. Risk factors for breast cancer can be affected by the amount of alcohol that we drink. That can increase our risk of developing breast cancer. Because breast cancer is often stimulated by estrogen, and we all have estrogen in our fat stores. That's how there's additional estrogen in our system. So being overweight or obese can also contribute to future breast cancer risk. Not being active, not having children, not breastfeeding, those all play a role in our amount of estrogen exposure. It's controversial whether or not birth control can increase your risk of breast cancer, but it does have estrogen in it. Same with the menopausal hormone therapies. There have been studies like the Women's Health Initiative that has shown that it can increase our risk of future breast cancer with prolonged use. With regards to ovarian cancer, that's a cancer that actually begins in the eggs or the ovaries. Risk factors include age. Any woman's at risk, but it does increase in our 7th to 8th decade. Increased weight, again, because of the hormone components. Not having children, again, exposes you to more hormones in your life. Hormone replacement therapy, if you have a family history of certain cancers, or you actually carry a gene that contributes to your future risk of cancer. Those genes like the BRCA gene or the Lynch syndrome genes do increase your risk of future ovarian cancers. So symptoms that should not be ignored if they persist for 2 weeks of every month and are going on for months at a time would be bloating, pelvic or abdominal pain, trouble eating or feeling full quickly, or urinary symptoms such as urgency or frequency. We'll definitely all have these from time to time, but if they're persistent, they last more than 2 weeks a month, and you're having them, for multiple months, they definitely needs to be investigated. As unfortunately, even in 2023, 70 to 80% of patients are diagnosed with advanced stage, and often surgery and chemotherapy are needed to treat their cancers. Uterine or endometrial cancer is a cancer that begins in the uterus, starts in the lining of the uterus. Again, weight you see is a kind of a theme in gynecologic cancer, again, because of the estrogen component. And starting your periods at an early age means you've been exposed to estrogen longer. So if you have any vaginal bleeding after menopause, it's important to be examined to see what's going on there. And also any bleeding between your cycles that seems abnormal and excessive also needs to be investigated. Often surgery, a hysterectomy, is recommended to treat uterine cancer, as 70% of uterine cancers are diagnosed quite early, and hysterectomy can be curative. If patients have more advanced cases, they may need either chemotherapy or radiation. Vaginal cancer and vulvar cancer, as previously mentioned, are often HPV related. Symptoms can include abnormal bleeding or vulvar itching. And if you find a palpable lesion on the labia or the vagina, it's obviously important to be examined. So the annual gynecologic exam, even if you're not due for your pap smear, is extremely important to check on your vulvar health, your vaginal health, your uterine, your ovarian health, your breast health, your overall mental and emotional and spiritual health. But definitely, even if you're not due for your pap smear, that doesn't mean you should skip the exam that year. So local advocacy resources that I've worked with that are advocating for gynecologic health and gynecologic cancers are the African American Wellness Coalition. There's the Kaleidoscope of Hope Foundation that focuses mostly on ovarian cancer and also has provided millions of dollars for ovarian cancer research. The New Jersey chapter of the National Ovarian Cancer Coalition is very active in our area. And the Turn the Towns Teal campaign is very active, particularly in the month of September, which is Ovarian Cancer Awareness Month. So I know it's a lot of information at once. I'd like to thank the GYN Cancer Collaborative, the Society of GYN Oncology, the Gynecologic Cancer Foundation, the slides provided from Merck to talk more about the HPV virus and vaccines, and Dr. Coleman from the University of Texas MD Anderson Cancer Center. And I think I'm finishing 3 minutes early. If you have any questions, I'm happy to take them. Thank you.
Thank you, Dr. Chabot. It was great information. Okay, we will get to the questions and answers now. So, Dr. Chabot, the first question is, what is the likelihood of having cervical cancer if the woman had a hysterectomy?
So if a woman had a hysterectomy for non-cancerous indications, her chance of developing cervical cancer is none because the cervix has been removed. If patients have had a supracervical hysterectomy, which means the cervix was preserved, but the uterus was removed, which is often done for fibroids or other abnormal bleeding concerns that are not cancer related, they should still go, for their pap smear screening. So that's important to remember. If your cervix was removed at the time of your hysterectomy for non-cancerous indications, you don't need to go for pap smear screening if you have a normal pap smear history. However, if your cervix is preserved, it's important for you to continue your pap smear screening as you would still be at risk for future cervical cancer.
Okay, next question is, should a woman go to her gynecologist first or to the oncology, GYN, if she is concerned about the possibility of cancer, etc.?
I mean, usually most patients start with the gynecologist first for their preventive care screenings. And if they feel their concerns aren't being addressed, or if the gynecologist has more concerns during the exam, then they're often referred to a GYN oncologist for further evaluation.
Okay, and next question is, recently diagnosed with HPV at the age of 58. So very grateful for the informative information. Okay, and next question is thickening of the uterine lining post-menopausal.
So thickening of the endometrial lining can sometimes be a condition which is concerning for hyperplasia, which is a precancerous condition of the uterus. We usually get concerned if patients are also having postmenopausal bleeding, because that could indicate a concern for precancerous or cancerous changes. So sometimes patients are followed by ultrasound, sometimes biopsies of the lining of the uterus are performed to exclude any underlying concerning cells.
Okay, next question is, how acute is a pap smear for a woman with vaginal stenosis, and is it a blind pap smear?
Sometimes if the vagina is smaller or closed from scarring or previous treatment, there are smaller speculums that can be used to try to visualize the vagina and or the cervix if it's present. Sometimes if that's too uncomfortable or not feasible, the brush can be placed into the vagina to get a sample of the cells at the top of the vagina and or the cervix.
Okay, next question is, how often should a 70-year-old get a pap smear?
So again, that's controversial because these guidelines have come out recommending pap smear screening stop at 65. Unfortunately, Medicare may not pay for pap smear screening in non-high risk patients. So that's always a concern if patients would have to pay out of pocket for their screening. If you have a normal pap smear history and a negative HPV history and no new sexual partners, then sometimes you can stop your pap smear screening. It's 65 to 70, we often say in the Society of Review and Oncology. If you have an abnormal pap smear history, then you need to continue to go for your pap smears for at least 30 years after the abnormal pap smear. So if your pap smears weren't abnormal to your 50s or 60s, then you actually would continue your screening past the age of 65 to 70.
Okay, next question. I had an abdominal paps until I got the HPV vaccine. Or I'm sorry, I got abnormal paps until I got the HPV vaccine. Then normal paps since then. Could the vaccine have done this?
Well, the vaccines are thought to be preventive, not treatment vaccines at this time. So it is possible that your body did clear HPV from its system, as the majority of patients will do so within 2 years of exposure. So whether or not the vaccine played a role in clearing the HPV from your system is a possibility, but it could also be that your own immune system was working to clear the HPV from your system already. But the benefit of receiving the additional vaccine was that you probably have not been exposed to the 9 different types of HPV available in the vaccine. So it did give some additional cross-protective benefit for other types of high-risk HPV.
Okay, we have 2 more questions.
Okay.
Next question is, does HPV cause labial pain?
The virus itself doesn't often cause labial pain, but if patients develop genital warts, those can be uncomfortable. They can cause itching. They can cause chafing of the skin against the clothes. Not typically HPV itself causing labial pain, but if you have a lesion as a result of the HPV, that could definitely be a possibility.
Okay. Next question, do you recommend Gardasil for postmenopausal women past age 55 with HPV?
So again, it's only approved up to 45, I believe, to receive the HPV vaccine that would be approved by insurance. Likely because if you've already been sexually active, you've already been exposed to HPV. So the benefit again is usually less if you've already been sexually active before you start the vaccine series. So typically I wouldn't recommend it in postmenopausal patients because again, it's a preventive vaccine, not a treatment vaccine at this time.
Okay, and we're just going to go with one more question.
Sure.
Question is, what tests are recommended for postmenopausal women whose lining is at 7 centimeters for 2 years with no bleeding now? Would you recommend a hysterectomy and a DNC?
So I think it probably would be 7 millimeters, not 7 centimeters. A normal endometrial stripe is 4 millimeters for a postmenopausal patient. Again, we get most concerned when patients are having bleeding with the thickened stripe because that increases your risk for precancerous and cancerous conditions of the lining of the uterus. I would definitely not jump straight to hysterectomy given those results so far. If it's stable, you could consider endometrial sampling to make sure you're not missing a polyp or some other growth in the lining of the uterus itself. So at minimum, I would do endometrial sampling or continued ultrasound monitoring, but I would not jump to a hysterectomy if patient did not have other risk factors.
Okay. Okay. Thank you for joining us. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to the survey has been also added to the chat area for your convenience. A special thank you to Dr. Chabo for dedicating your time and expertise today. If you have any additional questions or comments, you can send us an email to communityhealth@atlantichealth.org, or you can call 1-844-472-8499. I have also put that in the chat area. This concludes our webinar. Everyone, have a great day.
Thank you. Take care.